Today I would like to discuss about a topic that you may ignore in endocrinology, that is hypoglycemia. See, the theoretical definition of hypoglycemia is when the plasma glucose level falls less than 50 to 60 mg percentage, okay, or 50 to 60 mg per deciliter. But remember, this is just a theoretical definition. The individual threshold, okay, may vary from person to person. So, what are the symptoms of hypoglycemia? As far as symptoms of hypoglycemia is concerned, there may be autonomic symptoms, and second thing, neurological symptoms. So, autonomic symptoms: anxiety, sweating, tremors, palpitations. So, this is what textbooks is saying. But when you are seeing a patient in wards, the first classical symptom to pick up hypoglycemia is irritability. The patient will be highly irritable. Coming to the neurological symptoms of hypoglycemia, remember, number one is confusion. The patient may be drowsy, lethargic. The patient may throw seizures, okay? And in some cases, okay, rarely the patient may even get an episode of hemiplegia. That is why whenever a patient first comes with complaints of weakness of upper and lower limbs, the first thing to rule out is always an episode of hypoglycemia. Immediately check the blood sugar. The patient may sometimes also present with personality changes, restlessness. Okay, all these are rare manifestations. But remember, hypoglycemia has to be ruled out in any patient of unconsciousness when brought to the emergency department. So coming to the causes of hypoglycemia, the most common is critical illness. The patient may be having hepatic renal or congestive cardiac failure. The patient may be having chronic renal failure. The patient may be in septic shock. Or second thing is drugs. The most common drug which causes hypoglycemia is of course insulin. That is why we say that hypoglycemia is the most common complication in diabetes mellitus. The patient will be on OHA, oral hypoglycemic agent. The patient may be on insulin. So hypoglycemia is one of the most common complication in diabetes patient. After insulin, sulfonylurea, that is I told OHA group of drugs, okay, and then other drugs like sulfonamides, okay, antibiotics, sulfonamides, salicylates, okay, all those can precipitate an episode of hypoglycemia. And another rare causes, let us see, it may be because of an underlying hepatocellular carcinoma or any other tumors of the liver, okay, then tumors of the adrenal cortex, and another important endogenous condition, that is what we call as insulinoma, in which the patient will be having very high, okay, elevated levels of insulin. So how will you treat an episode of acute hypoglycemia? Okay, the patient can take something orally. Treat with oral sugars or food having high glycemic index. Suppose if the patient can't swallow, don't worry, give the magic drug. What is the magic drug for hypoglycemia? It is 25 to 50 ml of 50% glucose intravenously. Immediately push, okay, put a venflon, immediately push 25 to 50 ml of 50% glucose, okay, which is available as dextrose in our wards. Suppose if the patient is not conscious, not able to swallow, the other drug we can give is glucagon. Remember, glucagon should not be given intravenously. Glucagon should be always administered intramuscularly. Okay, yes, because glucagon's primary action is not only to increase glucose, it has other metabolic actions also. So glucagon is given 1 milligram IM. So that is the last resource. Very rarely we do that, but first we will always give oral sugars. If not, we will go for 25 to 50 ml of 50% glucose, that is so called as dextrose, which is available in the wards. And I would like to also mention about two important fasting hyperglycemic syndromes which are very commonly asked as MCQs in your exam. Number one is called Somogyi phenomenon and number two is called as Dawn phenomenon. What do you mean by Somogyi phenomenon? Early morning there will be hyperglycemia, early morning hyperglycemia following an episode of hypoglycemia at the night. Why? Because night the patient will be taking a dose of insulin, right? So after the night dose of insulin, so insulin will cause hypoglycemia. So in the late night, by some 2 a.m. or 3 a.m., there will be hypoglycemia. Following that hypoglycemia, what will happen? Our body will release counter-regulatory hormones like cortisol, glucagon, epinephrine, which will increase the blood sugar. So early morning, the patient will present with hyperglycemia. So how to prevent this? We have to reduce the night dose of insulin. So reduce the night dose of insulin in Somoggy phenomenon. What do you mean by dawn phenomenon? Dawn phenomenon is here also there will be early morning hyperglycemia, but in the late night also there will be hyperglycemia. This mainly happens in type 1 diabetes mellitus patient, and what is the theory they are telling is in these patients there is increased secretion of growth hormone. You know, growth hormone causes hyperglycemia. So in the night by 2 a.m. there will be hyperglycemia. In the early morning also there will be an episode of hyperglycemia. So what we have to do? We have to increase the night dose of insulin. Why we have to increase the night dose of insulin? So that in the late night the patient does not get an episode of hyperglycemia. Whereas in the Somoggy phenomenon we have to decrease the night dose of insulin so that the patient won't get an episode of hypoglycemia in the late night. Okay, so these are the important things you have to remember in hypoglycemia. If they ask us a short note, write the definition, write the autonomic symptoms, CNS symptoms, causes, that is either the chronic conditions, then the drugs, insulinoma, then tumors, then the treatment part, and write about Somoggy phenomenon and dawn phenomenon. So hope this is useful. So this is a topic that you may ignore during your routine reading. Read it. Okay.